Now it's time to review a topic which I think it's interesting for both for surgeons and for endocrinologists. It's called iatrogenic hypoparathyroidism, which is probably for sure, the main cause of hypoparathyroidism. More than 90% of hypoparathyroidisms are produced by the surgeons. And in this talk, I will try to summarize why we are producing hypoparathyroidism, what's the best way to prevent it, and some hints about the medical management, which I think is interesting. This paper is also based in our experience because since 1990, the surgeons in my hospitals, we have followed all the patients with postoperative hypocalcemia. So I can give you numbers, first-hand numbers, because in my unit, we'll never send to the endocrinologist a patient with hypocalcemia. We follow them until hypocalcemia resolves or after we diagnose permanent hypoparathyroidism. Now, the 80s were very relevant in terms of changing the paradigm for surgery, and many very respected endocrine surgeons proposed total thyroidectomy for benign conditions, as Tom Reeve in Australia, for cancer, or Clark, and even for Graves' disease. Norman Thompson, who unfortunately died last year, and was really one of our mentors for all the surgeons involved in endocrine surgery. And it's not by chance that the hypopara societies began to flourish just after this. You know, the first was the USA Hypopara Society and the Australian, of course. The initial surgeons in the initial countries where the patients were started to be organized for dealing with hypoparathyroidism. Then came the UK, the Germany, and the Scandinavian countries. So now we have plenty of societies of patients that have come together to discuss things relevant to hypoparathyroidism, and this has a close correlation with the increasing rate of total thyroidectomy all over the world. This also has meant that the number of papers related to hypoparathyroidism since 1901 have trebled. So from 40 papers a year now, we are seeing in PubMed with these keywords about 100 papers being published last year on thyroidectomy and hypoparathyroidism. And this also is related to the increased use of thyroidectomy and one of its more common sequelae. It's, again, not by chance that last year both the European Society and the American Society have published the guidelines for the management and diagnosis of permanent hypoparathyroidism. I'm sorry, Electron, but the Europeans are much better than the Americans. But they are there, and if you treat patients with hypoparathyroidism, I think you should read them because it's the first attempt to organize all the information we have about this not so common disease. Now, in the 80s and 90s is what I call the 0%, 1% years. All the surgeons had 0%, 2% at maximum hypopara rates, and everybody was very happy. But if you look carefully at the publications in the 90s, you'll see that we lacked precise definitions of this condition. Many surgeons were mixing emithyroidectomies were near totals and totals, so in the end you didn't know exactly what was the prevalence of hypopara in total thyroidectomy, which is the issue we are going to discuss. A small series, very incomplete follow-up. But one of the main problems of talking about hypopara is that the patients get lost. I mean, they are sent to the endocrinologist or the GPs all over the geography of your area, and in the end, if you don't follow them or there's no a single person following all of them, you really end up without knowing exactly what happened with this patient. There was some euphoria for total thyroidectomy, and there are a lot of conflicts of interest by surgeons publishing on this complication. Now the panorama has changed. You know, the 0% years are over, and in this type of publication, there's no conflict of interest because these are national registries or national records, and as you can see, it's not that bad. I mean, we are moving from 6 to 12% of permanent hypoparathyroidism. This is the results in the United States on the American College of Surgeons study on cancer treatment with a 10% permanent hypopara rate. In the UK, they are close to 12% hypopara rate, and in German multicentric studies from 9 to 25%. So the issue is not solved, and there is a problem there that we now know more exactly its exact prevalence according to the data we have from registries all over the world. Now, I will start by by proposing you a series of definitions that we have been using and publishing in Lung Surgery last year to know what we are talking about. I don't like the term transient hypoparathyroidism because at the time of postoperative hypocalcemia, you never know if this hypocalcemia will be transient or not. So please forget about transient hypopara and let's talk about postoperative hypocalcemia that we define as a serum calcium below 8 milligrams at 24 hours after surgery. Not at 10 hours, not the 48 hours, but next day or 24 hours after total thyroidectomy, or low PTH and requiring calcium and vitamin D at the time of hospital discharge. Now we have proposed and introduced a new intermediate definition of protracted hypoparathyroidism, which are the patients that after 1 month, 5, 3, 6 weeks after surgery still require vitamin D and calcium treatment because of low and undetectable PTH at 1 month. And finally, the permanent hypopara, which we diagnose after 1 year. There's a controversy here, for example, in the European guidelines. I disagree with that, but that's what it came at the end. They talk about 6 months, but 12 to 20% of patients with permanent or so-called permanent hypopara at 6 months recover the function of the parathyroids between 6 months and 1 year. And even some patients may recover parathyroid function after 1 year. But for the working diagnosis, for working purposes, we will use the definition of permanent hypopara at 1 year. And then I subclassify this as aparathyroidism in patients with undetectable PTH, hypopara, detectable but low PTH, and relative parathyroid insufficiency, which means the patient may have a normal calcium and normal PTH, but when you stress the parathyroid, the calcium falls, for example, in malabsorption or gastric bypass or biphosphonate therapy. So let's go through these different syndromes of parathyroid failure. We use this definition of postoperative hypocalcemia, calcium below 2 millimoles or 8, because at the end you have to have some definitions. There was no definitions in the 90s. Some people use PTH, some use serum calcium, but not at 24 hours. We shouldn't correct serum calcium. Ionized serum calcium, it's not a particularly good test because serum ionized calcium depends on pH and transport. So at the end, we are using this definition for postoperative hypocalcemia. We don't correct for proteins because 8 is a little bit lower than normal, which is 8.5, 8.6. It corrects for recumbency, it's cheap, it's fast. So that's the definition we are going to use to define postoperative hypocalcemia. And it's quite predictive. So it's very rarely that the patient develops hypocalcemia after 24, 30 hours. Maybe in our experience, only 4 or 5% of the patients will have what we call delayed hypocalcemia 24 hours after surgery. Now, this is how these definitions work. That's our series of total thyroidectomy up to 2013. And that's total thyroidectomy, and that's the percentage of hypocalcemia, which is 42%, and a few patients develop what we call delayed hypocalcemia. Most of them are normal calcemic. Then of patients with hypocalcemia, most of them, about 2/3, will recover in the first month, and about 1/3 will go to protracted hypoparathyroidism. A few patients with calcium normal within 24 hours, very few of them, but some of them will present protracted hypoparathyroidism. So about 18% of our series will have hypopara at 1 month after surgery, and finally, after 1 year, we have a 4.5% of permanent hypoparathyroidism and 75 recover rate. So that's the nomogram, that's the flow chart of our patients, and now we will focus on these 3 different stages of postoperative parathyroid failure. Now, the first one is the pathogenesis. There have been a lot of papers on many fancy things, calcitonin, vitamin D, hungry bones, alkaline phosphatase, but, you know, be realistic. The problem is low PTH. So the surgeon is killing the parathyroids by doing different things, and at the end, what is evident is that we reduce the functioning parathyroid parenchyma, and we have a low PTH shortly after surgery. In fact, Marcin Barsinski did a very nice study, and if you have a PTH below 10 picograms at 4 hours after total thyroidectomy, for sure you are going to be hypocalcemic at 24 hours. So this links very much our definition with the idea of having a predictor of postoperative hypocalcemia by detecting and testing PTH soon after surgery. That's a very sensitive test with a very high prediction. So why does PTH fall after a total thyroidectomy? Well, some of the parathyroids may have been removed because the surgeon did not see them. One, in this case, the parathyroid was completely intrathyroidal. In other cases, it may be hidden on the nodules. So accidental parathyroidectomy leads to a reduction of parathyroid parenchyma. Unfortunately, after Samuel's papers on transplantation, somebody thought that auto-transplanting the parathyroid glands was a good idea. And from the Wells papers where Samuel was transplanting hyperplastic glands, some people started to transplant normal glands. And for many years, that has been a standard in thyroid surgery. Whenever you doubt about the vascularity of a parathyroid gland, you remove it, you cut it into pieces, and you insert them into a sternocleidomastoid muscle. That's a disaster. And finally, extensive surgery. Of course, the larger dissection you perform, you run the risk of devascularizing the parathyroid glands or even resecting the parathyroid glands. So in the end, what happens is that you lose your parathyroids. In this case, for example, there was a metastatic papillary metastatic node here, which is very close to the parathyroid gland, that was removed when resecting these metastatic nodes. Some of the parathyroids are completely intrathyroidal. About 3% of the parathyroids are within the thyroid. So there's no way a surgeon can preserve these parathyroids. Some parathyroids have very tiny vessels. Look at the inferior thyroid artery and these very tiny parathyroid arteries. So it's easy to devascularize the parathyroid if you don't look very careful for the vascularization of the parathyroid. In fact, in the 70s, Joseph Atty, a surgeon from New York, was proposing that all the surgeons should wear loupes, because with the loupe, you can see very, very well the vascular, vessels going to the parathyroid glands. But this can be, of course, devascularized. So we propose to use this new term. We call it PGRIS. PGRIS is the name we give to the number of parathyroids that remain in situ. So some of the parathyroids are gone to the pathology lab. Some of the parathyroids are being transplanted. So in the end, how many parathyroids are still in the same place? That's PGRIS, okay? That's the concept we are using, and I will convey the message that PGRIS is essential to understand the pathogenesis of hypoparathyroidism. So whenever you see PGRIS in my slides, it means the number of parathyroids remaining in situ, not resected and not autotransplanted. Now we go for the understanding of postoperative hypocalcemia. There's no much secret there. So usually younger patients, more females, and the extent of surgery are very crucial and well-known factors. There may be others, but these are the most relevant ones. So if you perform more extensive surgery, the prevalence of hypocalcemia goes up. That's for isolated total thyroidectomy, and that's for total thyroidectomy, central neck dissection, and lateral neck dissection. So extension of surgery is crucial to understand post-operative hypocalcemia, but also very important, autotransplantation. If you transplant the patients, you are going to have a lot of hypocalcemias. And finally, pigris. Now, pigris is interesting because if you leave in situ only 2 glands, the probability of having hypocalcemia is really almost 75%. Whereas if you leave the 4 parathyroids in situ, your prevalence is half, is just 35%. So if you don't send the parathyroid to the pathologist and don't transplant the parathyroid in the muscle, you will have the lowest possible rate of hypoparathyroid, at least in our hands during these years. Now, post-operative hypocalcemia, you manage that in different ways. Some surgeons will give routinely calcium to all patients. It's what I call the preventive strategy. I will give everybody calcium, so I will check PTH next month, but just in case. We don't like it. We will do very, very little preventive strategies, perhaps in patients with thyroparathyroidectomy for primary HPT and goiter, for example, or in patients with very aggressive surgery, but we don't really like to give follow a preventive strategy. Neither we like to wait for symptoms. In 2016, there's no rule for, if the patient develops symptoms of hypocalcemia, we will treat him or her. We should treat before symptoms appear. So what we are doing is treating the patients according to serum calcium. So if at 24 hours the patient is hypocalcemic and our PTH is low, we will start calcium and vitamin D right on the first postoperative day. Now, the patient is sent home, and the patient has had hypocalcemia, and the patient has been treated with calcium and calcitriol. Now we see him or her in the outpatient clinic the next week, and we ask for PTH and serum calcium at 3-4 weeks to investigate whether the patient will come back with function of the parathyroids, or he still has hypoparathyroidism. What's the risk factors for protracted? Which patients cannot recover the parathyroid function during the first month? Where at that time, all the clinical and surgical variables start to lose importance. Some of it you can still see for extension of surgery, but really what happens is that pigris is becoming more relevant. So if you left the 4 parathyroids in situ, only you will have 13% of your patients requiring treatment for over 1 month. But if you have only 1 or 2 parathyroids in situ, that's going to be a much worse situation, where about half of the patient at 1 month will still require treatment. So as far as we move away from surgery, the clinical and surgical variables are losing relevance, and pigris, another variable I show you in a minute, are more relevant concerning and regarding the future of the patient. So pigris is essential to understand protracted hypoparathyroidism. And now let's put the different metabolic and clinical syndromes together and play with pigris. Now you see here the 3 groups of parathyroids remaining in situ and how they behave in terms of hypocalcemia, protracted hypoparathyroidism, and permanent hypoparathyroidism. From time to time you hear the surgeon say, oh, yes, unfortunately I removed 2 parathyroids, but the patient has 2 normal parathyroids and it will do okay. Yes, it will do okay in about 85% of the cases, but the rate of hypopara with 2 parathyroids is close to 16%. So there's no guarantee that leaving in situ 1 or 2 parathyroids will prevent permanent hypoparathyroidism. And if you look at the biochemical values, also correlate pretty well with the amount of parathyroids or the number of parathyroids that you have let in situ. Now, why we insist in this definition? Because patients with postoperative hypocalcemia, there's not a single parameter allowing us to predict permanent hypopara. There have been several attempts of surgeons and endocrinologists say, well, if the serum calcium drops below 7 or if the PTH is undetectable, this patient will have hypopara. No way. At that time, you don't have any single variable predicting potentially hypoparathyroidism. But at 1 month, things start to change. That's the definition. We are very uncertain about the prognosis of this patient who still has a low PTH and requiring treatment. For sure, it will need a prolonged follow-up. And now we can start to make some predictions. Overall, 25% of patients who have protracted hypopara will develop permanent hypoparathyroidism. And if the PTH is undetectable at 1 month, 2/3 will become permanently hypoparathyroid. And if the the recovery rate for detectable PTH is 65%, but if you have undetectable PTH at 1 month, only 35% of chances of recovery. And the worst thing is at this stage, you can do nothing. Just wait. So far, we don't have any specific treatment for protracted hypopara. But I give you some hints of what makes a patient recover from protracted hypoparathyroidism. We know that about 70% of patients with protracted hypopara will recover, and I will try to show you the most relevant variables of patients that recover from protracted hypoparathyroidism. So let's go to why patients go from protracted to permanent hypopara. Now, it's time to quote a seminal paper in the late 90s where these French authors, although the paper has many methodological flaws, but when we realize our findings, we look back at the literature and we saw something which is particularly relevant about what I'm going to say to you. This group of Lille, Charles Prat, also a good friend and mentor of mine, suggested that if you have a delayed serum calcium above 8, the chances of recovery are much more like that the patient has a low serum calcium, delayed. Now, this is a very vague term, meaning that it's not a postoperative calcium, it's calcium detected sometime at 2, 3, 5, 6 weeks. But that's the first time that the serum calcium showed up as a potential variable. Now, serum calcium at this stage is the result of your treatment, because this patient had hypopara, so serum calcium is the result of giving the patient calcium and calcitriol. Now, what we saw is that depending on your serum calcium at 1 month, your chances of recovery are very different. So if your parathyroids have been bathed with a serum calcium of 9.6, and you have undetectable PTH at 1 month, your chances of recovery are over 80%. But if you have undetectable PTH and a serum calcium of 8, your chances of recovery are less than 30%. So that was intriguing. In some of the traditional texts you read, then you have to keep the serum calcium low to stimulate the parathyroids, okay? That's been written. Nobody has proved that, but it was kind of a traditional saying that if you treat the patient and leave the patient at 8 or 8.2, 3, it's better than having. Okay, our results are completely opposite to that. Not only for undetectable PTH, but also not that much for detectable PTH. So patients with detectable PTH had also a higher rate of recovery from protracted hypopara if the serum calcium at that time was 10 or more. So this led us to hypothesize, and this also has to be, when we looked at pigris and serum calcium, that was done 5 years later. There was a 2015 paper. We did the same analysis, but now with different pigris groups. And again, you see that the best for the patient is to have 4 parathyroids and a serum calcium over 9 or 9.5. Your recovery rate will be close to 100%, even if at 1 month you are still hypoparathyroid. But if you have only a few parathyroids and your serum calcium is low at 1 month, you are really, really in a bad situation. So that's what we call the moment of truth, and that's the difference between having a serum calcium or 8 or 80 and having 3 parathyroids in situ with a 50% chance of recovery rate, or having the same number of parathyroids in situ, but a treatment over 9.5 and 9.7. This we call the parathyroid splinting hypothesis, which means that the reduced and probably ischemic parenchyma of the parathyroid requires rest in a normal high environment to restart PTH secretion. So our findings suggest that you should not leave this patient hypocalcemic during the first month after surgery. You have to splint the parathyroids, exactly the same as you splint the lung or the kidney when they fail. You never give furosemide in a patient with acute renal failure. You put them into dialysis, okay? So that's the same for the parathyroids. And now we've done another study, multi-center study in Europe, and again the same finding. So I think it would be difficult for us to refuse our hypothesis. At least for the time being, our findings suggest that parathyroid splinting is a relevant measure to take after surgery to improve the recovery of the parathyroid function. Now, what about autotransplantation? Now you have here the patients. At the time we did all those studies were ending in 2011 and 12. We were quite liberal doing parathyroid autotransplantation. About 20% of our patients with total thyroidectomy had 1 gland transplanted. This, in some series, even is low. I mean, there have been studies suggesting that you should transplant routinely at least 1 parathyroid to make sure that it will work and prevent postoperative hypoparathyroidism. But in our unit, we were a little bit conservative, and now we are much more conservative. You see the results are so clear-cut. I mean, many people were saying, yes, we are going to see more hypocalcemias, but in the long run, the parathyroid transplanted will work and will prevent hypopara. Well, that's not true. Hypopara rates are 3-fold in transplanted patients compared to non-transplanted patients. And protracted hypopara is 2-fold. And this also bears a very clear-cut relation with biochemical values. So in patients with parathyroid autotransplantation, you see not only hypocalcemia, but also PTH is much lower at 24 hours and also at 1 month after surgery. Now, let's look at the issue in a different way. I love this slide. This is pigris 3 people. So people that have only 3 parathyroids in situ. The 4th parathyroid is either transplanted or in the pathology lab. And it's exactly the same. Isn't it amazing? Of pigris 3 patients, 110 were autotransplanted and 76 were accidental parathyroidectomies. So the pathologists recover 1 parathyroid in the specimen. Well, that's the same. It doesn't make any difference. You have the same rates of hypocalcemia, the same rates of protracted hypopara, the same rates of permanent, even some more permanent here, and also the correlation with biochemical values are exactly the same. So this is a new way of looking at the long-term results of parathyroid autotransplantation, and as you can see, the future of autotransplanted patients is not good. So we are, for the last 3 years, we have almost abolished parathyroid autotransplantation, and we are now much more keen on preserving the parathyroids in situ. And finally, There's an interesting group of patients that will have a normal PTH, let's say 30 or 35, and suddenly they become hypocalcemic. And the PTH continues to be 35. I mean, if you or I become hypocalcemic because of biphosphonates or gastric bypass or malabsorption or diarrhea, our PTH will go up to 100 or 120, okay, picograms ml. But if your parathyroids have lost some of the parenchyma and the reserve of the parathyroid function is marginal, you are not able to cope with this increasing demand. And this is becoming quite an issue because we are seeing patients with vomiting or diarrhea after surgery for different situations, for example, for GI disease or chemotherapy or malabsorption, biphosphonates. This is becoming an issue. That's very bad. I mean, if a patient with gastric bypass develops permanent hypopara, my God, you are going to be really in trouble. And I think the endocrinologists here, I don't know if any of you has some experience of that, but it's very difficult for these patients to be managed with oral vitamin D and calcium. Biphosphonates are becoming a very much used drug, and they lower the serum calcium, so be careful because treatment of osteoporosis may lead to hypocalcemia, lactation, even severe vitamin D deficiency. We are not aware of, a comprehensive paper on relative parathyroid insufficiency, and we are now focusing on this not very big, but certainly existing group of patients that develop hypocalcemia because their parathyroids have not enough functional reserve. So to conclude, factors relevant for postoperative hypocalcemia are gender, extension of thyroidectomy, and pigris. But as we move away from surgery, pigris becomes a more relevant variable, and also serum calcium concentrations and detectable PTH. This triad of variables are critical and crucial for patients recovering from protracted hypoparathyroidism. For surgeons, it appears essential to avoid accidental parathyroidectomy and autotransplantation. So we are becoming more and more aware of the relevance of leaving the parathyroids in situ. And finally, our hypothesis of parathyroid splinting seems to prove okay, and we now are trying to keep our patients above 9 after surgery because this may improve the long-term prognosis of postoperative hypocalcemia. That's the happy parathyroid with calcium and calcitriol. And I want to dedicate this talk to 3 monsters of endocrine surgery. The 3 of them insisted on leaving the parathyroids in situ. And unfortunately, during the 80s and 90s, many surgeons did not attend their opinions. They went on transplanting patients and leading to an epidemic of permanent hypoparathyroidism. Thank you very much.